Hello, everybody. Good afternoon, good evening, and good morning. Welcome to our third webinar organized by One Health Bangladesh in collaboration with Global Health Development. Before we embark on the webinar, I just want to share our deepest respect to our legendary professor Anisuzzaman, who has just passed away last evening. He was one of the most respected intellectual in our country, and we express our deepest sympathy and pray for the departed soul. And it is an irreparable loss for our nation. With showing that respect, I am just going to start the webinar today. As you all know, our today's topic is what is working and what is not working in tackling COVID-19. We have two distinguished speakers here today. One is Professor David Heymann, whom some of you might know him very well. He is a distinguished fellow, Global Health Program, Chatham House, former director of Communicable Disease Branch of WHO, and professor of London School of Tropical Medicine. He's also a One Global Public Health and One Health leader. And we are very fortunate that he is here today. And he is still very active in supporting WHO and different organizations, including UK government, with COVID-19 crisis. Our second speaker, who is very much known to you, Dr. Hussein Rahman, and as you all know, he's an economist, but also one of the strong advocates of a health policy, particularly the urban health policy and implementation. He is the chair of BRAC Bangladesh, as well as the executive chairman of Power and Participation Research Center. We are very fortunate that both of them have agreed to talk today on the topic. And before I go to opening the session, just some housekeeping. Please remember, this program will be recorded and then uploaded in our website. All participants can ask questions in the chat box, and we will be a little bit selective. It will be a 1-hour session. And I hope that our distinguished speakers will answer to your question. With these few words, I just want to start our today's webinar, and it will be started by Professor David Heymann with a brief presentation. David, please.
Thank you very much, Nitish. Are you hearing me all right?
I am hearing you very well.
Okay, fine. Well, it's really a privilege to speak with you today. And what I'm going to speak a little bit about is what we know about the SARS coronavirus 2 that's causing the current pandemic of COVID-19. And it would just be probably best to start with what we know about coronavirus infections. And on this slide, you can see that there are 7 different coronaviruses. There are 4 coronaviruses that are called seasonal, and those viruses remain in human populations. They're endemic. And each year in the winter months or in the dry season, they cause respiratory infections, mild usually, and it's called the common cold. And you can see that their animal origin has been associated with some type of animal from the animal kingdom. These viruses don't just come in on the tail of a comet or some other way. They come in an animal, and they breach the barrier between animals and infect humans. Then there have been 3 epidemic coronaviruses. The SARS coronavirus in 2003, which emerged from, it's thought, a civet cat in the Guangdong province of China from a live animal market. MERS coronavirus that emerged from camels in the Middle East. and SARS coronavirus that is thought to have emerged from some type of an animal in a market in China. But these three epidemic coronaviruses have all had their origin in bats. Bats carry coronaviruses, and these then either infect humans directly or through an animal intermediary. The SARS coronavirus outbreak in 2003 actually is thought to have begun in November 2002, and it then spread to many different countries around the world, causing outbreaks. And it was a virus which could be interrupted in its transmission by outbreak containment measures, and it was eradicated from the world. The laboratories, the only viruses of SARS coronavirus that exist today are in laboratories. And there have been some laboratory accidents that have infected humans in Singapore, in Taiwan, and in China. But the SARS coronavirus was a one-time mutation, either in an animal or a human, that then infected humans and spread around the world. The MERS coronavirus continues to cause sporadic human cases because it's a virus that's carried in the nasal passages of camels. And infected camels don't get sick, but they can transmit this virus to humans, and occasionally the virus then causes an outbreak if there's nosocomial transmission or in other ways. And so there have been outbreaks of MERS coronavirus periodically, and the major one was a nosocomial outbreak in South Korea, introduced by one person traveling there with this infection from the Middle East, and then poor infection control in hospitals spread it to 7 different hospitals. The SARS coronavirus 2 outbreak is the epidemic that we're witnessing now. It's become a pandemic, and we'll talk about that now in detail. We know a lot about this virus, but there are still some things that are unknown. We know that it transmits from human to human through droplets, and those droplets can occur when people speak or when they cough or sneeze. We know that people 1 to 2 days before symptoms develop can transmit this infection to others. We don't know if people who remain asymptomatic throughout the course of their infection can transmit to others, but we do know that sometimes they shed virus. And we don't really understand the ease of transmission completely, but we know that it transmits very easily. And here's a good example of that. This is a choir practice.
Video conference, international.
Okay. This is a choir practice in the state of Washington in the United States in March, a couple months ago. One person was sick and came to choir practice, and there were 32 confirmed and 20 probable cases that resulted from that person, and a total of 87% of all people who were at that choir practice became infected, probably from droplets as people were singing or coughing. This person was sick, so he was likely coughing and spread it to all these different people. The groups at risk we know pretty well as well. We know that the elderly, people over 65, and those who have comorbidities such as obesity, hypertension, cardiac disease, and diabetes are at great risk of infection. And we believe also smokers are at a greater risk of infection, and those with chronic pulmonary disease. We don't completely understand the natural history of infection. We don't know how many people are infected and remain asymptomatic. But we do know that of those people who become symptomatic, 80 to 85% have a mild infection. The rest have a severe infection, which many times leads to respiratory failure and necessity for ventilation in a hospital. We also know that of those who are ventilated, 50% only will recover. And the mortality rate is oftentimes due to the health system ability to provide patient support. We know, for example, in Italy, that where there were many deaths, those deaths occurred because people couldn't get into hospitals that were overcrowded, and many times there weren't ventilator support available for them, and they died oftentimes outside of hospitals. And we don't yet know the long-term effects from infection, although we do believe that, as in patients who had recovered from SARS coronavirus, the SARS coronavirus 2 will have long-term effects, including possibly fibrosis of the pulmonary system in certain of those who recover. We know that outbreaks can be contained, and this is unlike influenza, where outbreaks cannot be contained. These outbreaks can be contained by good public health policy, diagnosing of patients and isolating them. So first of all, a surveillance system to identify them, then diagnosing them and isolating, tracing their contacts, isolating contacts, making sure that if contacts become sick, they're tested. If they're COVID positive, they're isolated, having a surge capacity in hospitals, and having protective equipment in health facilities. Countries in Asia were very well prepared for this outbreak in South Asia: Singapore, Vietnam, Taiwan, Hong Kong, South Korea. They've been able to keep the reproductive number, that is the number of people who are infected from one infected person, less than 1, meaning that they haven't had a rapid increase in infection and they haven't had a surge on their hospitals. Countries in Europe have done a worse job than they have in Asia. And Germany has done quite a good job in outbreak containment activities and in decreasing the burden on their hospital beds. Other countries haven't done so well. And most countries in Europe locked down, and they're beginning to unlock with unlocking of facilities such as schools and parts of the industrial sector. So there's also a role for individuals to play in outbreaks as well. And that requires understanding by people that they must physical distance, remain about 2 meters away from other people, even if they're not showing signs and symptoms, because they may be infected and pre-symptomatically transmitting infection. Contaminated surfaces are surfaces where people who have had infection might have spoken and contaminated, and they must be cleaned. People must begin hand washing and make sure that they practice hand washing on a regular basis, and that if they're sick, they should be wearing a mask and sneezing into their elbow. And people wearing masks when they're sick are doing that to protect others. It's clear that wearing a mask to protect yourself is not effective because the eyes are still exposed, and eyes are an entry point for virus. SARS coronavirus 2 develops antibodies, as do other coronaviruses. And this is just a scheme to remind you that there is serum antibody produced by B cells during infection with the SARS coronavirus 2. There are serological tests available, and there are animal models being studied on immunity. But we understand very little about immunity. We know that other coronaviruses that cause the common cold, represented in orange here, do provide some short-term immunity, but that immunity is not long-lived, and people who are infected with a coronavirus this season can be infected a year later with the same coronavirus. We don't understand much at all about immunity for SARS coronavirus 2, but we're beginning to understand more. And for serological testing, we're beginning to understand that people do produce IgG and IgM antibody, but that doesn't begin until about the beginning of week 2, and you can see here that before then, the only way of detecting infection is by detecting the antigen through PCR testing. Then antibody can be detected, and you can see that IgG remains high, whereas IgM, which is that acute antibody, decreases quite rapidly. That's the vision of how this infection is occurring based on understanding from the SARS coronavirus. So where do we stand in diagnostic tests, drugs, and vaccines? Well, as you know, there are various types of vaccine under development and study. In fact, there are messenger RNA vaccines that will produce a response in humans similar to the virus because they reproduce in the messenger RNA reproduces in human cells. There are vaccines made of virus-like particles looking to imitate the spike protein that, as you know, is where you want to develop immunity. There are vaccines being studied that are based on killed virus, and possibly also some live attenuated vaccines will be studied. There are over 95 vaccines being studied. None of them is guaranteed to be available, to be effective. And if they're effective, availability will be very difficult because there isn't capacity at present to produce those vaccines. So some countries are actually beginning to develop capacity and producing vaccines that are under study, hoping that they will be effective and licensed. Then there are antigen antibody tests. There are very good antigen detecting tests, the PCR. Antibody tests, there are some that are validated, but the best antibody test to date is a neutralizing antibody in the laboratory, which depends on a laboratory to neutralize a virus with the antibody that's isolated. But there are some other tests which are being developed, and there are many rapid diagnostic tests. None of these have been fully validated, so they need to be validated before they're used to determine their sensitivity and specificity, to be sure that they're not picking up other coronavirus antibody, and to be sure that they're picking up all those people who are infected. We do know that antibody is very low in people who have mild infection, mild disease, and so some tests may not be sensitive enough to pick up all antibody. There's also a study of repurposed drugs. You'll know that remdesivir is being studied, a viral antiviral drug that appears to be effective in Ebola is being studied, and it's been shown so far at least to shorten the time to recovery, but not certainly to cure infections, and studies continue with that. There have been other studies on hydroxychloroquine and on azithromycin, and those studies have pretty clearly shown that these drugs are not effective, although studies do continue in a case control manner. And there are studies using antibody collected by plasmapheresis from those who have recovered, and there are studies on monoclonal antibodies developed in laboratories. But none of these tests have been shown to be, so far, none of these antibodies have been shown to be effective so far. And remember, we don't yet understand whether or not this virus does produce lasting immunity. So many countries are now transitioning out of lockdown. They're doing risk assessments. They're deciding where and when to start transitioning. And it will be important as they do that to monitor where they're unlocking their sectors to be sure that transmission doesn't increase. And they must have in place a means of outbreak response, identification of patients, identification and testing of contacts. And so what we're seeing is that countries many times lock down without any understanding of what they might do after they unlocked. So they lock down to decrease the number of cases which would have occurred without those measures that they felt might have occurred, and they've lowered the curve, as you can see. So what is happening now is as people are transitioning, as countries are transitioning, they need to watch to make sure that that level of transmission remains low, and they need to continue monitoring and continue doing risk assessment. So Nitish, that was what I had to say. Thank you for having invited me to speak with you, and I'm now turning it back to you.
Thank you, David. I think that's a very insightful presentation, and there are a lot of questions already I am receiving, and you will have to answer them later on. I will now request Dr. Hussain Jillur Rahman to come up with his inaugural comment. Dr. Hussain Jillur Rahman, please.
Thank you, Nitish, and thanks to David Heymann also for the presentation. I think your title for this webinar was "What is working, what is not working," which is looking at the practical realities on the ground. So I'll make some comments from that vantage point. Some words, these words were not in vogue before: lockdown, social distancing, quarantine. They have become very familiar now. And I think one of the issues that we have found in terms of what is working, what is not working, is, there is the knowledge, as we saw from the presentation by David Heymann, the scientific knowledge is well laid out. but how that knowledge is translated in terms of action points, I particularly focus on the issue of the communication strategy from the government, from the authorities, for ensuring the response from the public. And I think this is an issue where we really need to look at much closely, because some countries have, of course, some countries have a prior strong public health system, and therefore they're in an advantageous position. That's a different matter. But I think the quality and efficacy of the communication strategy itself is very, very critical variable. In the Bangladesh context, we find that there is a lot of areas of concern on the whole issue of communication. One, of course, is, and I think also a related issue I want to say is that the social distancing prescription, we also need to ask the question whether this is, to what extent it needs to be customized for different country context. For example, overcrowded urban cities of countries like Bangladesh, poor informal settlements. In those realities, the prescription on social distancing, how is it going to work? That's a very important issue, actually. And I think here are issues about also, David Heymann made a distinction between the public policy and the personal actions. But there are also issues in the public policy I think we can add, for example, in the informal settlements, where there is a scarcity of water, of opportunities for regular hygiene, etc. There is a public issue about public hand washing stations as an important intermediate variable. So what I'm basically trying to get at is that the communication strategy, the social distancing prescription, these we need to, what is working and what is not working, we need to really ask in a way, unbundle these to understand what is working, what is not working. In the Bangladesh context, we even look at the word we have used instead of the word lockdown. We have called it general holiday with restrictions. Initially, general holiday was the word which got into people's head, and they immediately went for their holidays, visiting sea beaches, festivals and all that. But now people have understood that it's something more. It's a lockdown is the word they actually use in their own discussions, even though government continues to use general holiday with restrictions as the language. But one thing that Bangladesh is, I think, if I look at what is working, one angle, is that we have a situation of a lax enforcement of lockdown in communities, in cities. But one important policy decision has been, and which I think has been a right one, is that intercity travel, particularly closure of public transportation, has been important to ensure that the infection doesn't travel from the hotspots. At least you reduce the possibility of that. And even now, there is great, it's a very relaxed enforcement of lockdown that's happening, but the public transport, intercity transport ban remains in place. Though people are traveling with private cars, etc., but the fact of the public transport ban, I think, has been an important one, at least in the Bangladesh context, to give some measure of the lockdown. Communication failure, not failure, let me not use the word failure, but communication challenges. One of the other point is that there has not been a sufficient attention to explaining what the what the coronavirus, the novel coronavirus is, it is all about. And as a consequence, I don't know in other countries, but I was with another webinar with some African countries yesterday and I found similar problems there, is that you have to get your handle on the communication from the very outset. In the Bangladesh context, what we see is that because of the way the communication was not done from, for example, from the very top, it was seen as a departmental responsibility, mid-level health ministry people doing that. But meanwhile, there was this flood of information coming via the social media, international media, online media, etc. So as a whole, what has happened is still now around the issue of coronavirus, there is a panic syndrome, has really very strongly in place in Bangladesh context. And this has had some consequences. For example, the corona patient is seen as a villain. And there are instances where people who were identified with corona, their building was attacked actually. Like that person is a criminal. He has to be somehow thrown out of this locality. So that's one type of we had a very, still now that sort of a attitude in some quarters still persists. The other problem has been because of this panic syndrome. During these periods, people are also sick for other reasons. Kidney patients are there, heart patients are there, other reasons, People will go for childbirth, etc. But the non-corona healthcare, there has been a dramatic drying up of non-corona healthcare. And you have horror stories of dialysis patient traveling between hospitals and unable to get because of that fear. And we have, of course, a problem that insufficient testing has also added to that panic syndrome. So I would, to start with, make these two major points, that the communication strategy is a very, very critical area to look for what is working, what is not working. And also the social distancing prescription, we need to really spell it out in customized manner for different kinds, particularly for poor environments where people of necessity are having to, in a way, live in very crowded environments. One thing which may be happening in the Bangladesh context is that at least those who could, there may have been a migration back to the villages. For those who could do it, we had done a survey and we saw that not all did it, but for those who could do it, they have gone back to villages which offer a somewhat of a more relaxed circumstances for ensuring social distancing. That's an issue. The third point I will mention and end there is that during this period, any effective engagement on this new epidemic has to address the issue of how we balance the issue of the health and the economics. We conducted a survey in mid-April and we found that rural and urban poor both have suffered a 75% decline in their income. And there is this, from the bottom, there is this pressure of how to deal with that. Some of it is about social protection by the government, how much government can do. So I think the big challenge, David Heymann mentioned that now we are from the lockdown, we are going to transition phase. But I think in this transition phase also we need to unpack, ask the question of what will work, what will not work, in terms of how we ease the lockdown, what type of economic activities we allow first to come on board, what we allow not to come on board earlier on. I think that's a very important issue that we need to consider. And I think these issues are matter not for the health. It's a, I got engaged with this word One Health because I do feel I'm an economist, but I feel that now health has to become a concern for not just the health professionals, for the economists, for general people, for the budgetary people making the budgets all across actually. That is the thing that we should be also be engaged with. So I'll stop there for the moment, Nitish.
Thank you
You are
very
on
much,
mute,
sir,
yeah.
for your very insightful discussion. I have quite a good number of questions for you. I'll come back to you later, but I will start with David. David, you have quite a good number of questions, but I will start with what do you think about this herd immunity? You know, there are a lot of discussion around the global horizon and also in our community, our professionals. What is this concept of herd immunity? Is it really working? Or can we give up everything in the name of herd health? What is your response?
Thank you, Nitish. The problem at present is that we don't understand whether the antibodies that are developed after infection are playing a role in immunity. As you know, herd immunity means that enough people have been either infected and developed immunity to prevent further transmission. So it takes quite a high number of people to have been infected and then to have developed protection. And we just don't know if that's possible. But there is actually a country which is trying to see whether or not this might be effective, and that is Sweden, which has allowed the virus to enter the country in a very slow manner because they do stop major outbreaks. They're asking their populations to physically distance, and they're doing a series of things which they hope will slow down but not stop the entry of the virus. They so far have 24% of people in Stockholm who they believe have been infected, but that's nowhere near the number that would be required for herd immunity should this virus produce antibodies that do protect against future infections. Thank you.
Thank you, David. Now I'll go to Dr. Hussein Rahman. In terms of this strategy or communication strategy that you have emphasized, do you think that community engagement could give some sort of solution in this pathway? What is your thinking about the community engagement in COVID-19 tackling?
Right.
Can you respond to that?
Yes, certainly.
Yeah, please.
Certainly. Of course, community engagement is very critical, but I think community is one side of the picture. The other side, who is going to engage with the community? I think on that we need to bring that also into the discussion. What I mean is that, for example, across society, communication is being done by the government, via official announcements, etc. At the level of community engagement, yes, very important issue. But there, for example, say if I want to work in Dhaka slums in Dhaka city, now who are going to do that?
Yeah, there is a question of that as well, yeah.
So groups of, is it a dedicated group of professionals who have come up with a better sort of a communication strategy? So community engagement, absolutely important in terms of ensuring that eventually the people at large are working. But I think we have to work on both the nature of the communication strategy from the top. We have to get the right messages there, because I still see that the panic syndrome has not been clarified sufficiently, and we need to really work on that. Why can't the private hospitals deal with the non-corona problems? They're not doing that actually. There's a problem there. Government needs to come out with that. But at the same time, health sector professionals, other interested groups, they are, I think, they can not community understood as Bangladesh community as a whole, but segments of the community, say slums in Dhaka city, or in small Purushabhas, dealing with the mayors, come up with some sort of a strategy, engagement there. And there also we need to make sure that this social distancing is not like a textbook type of prescription, but customized to those realities. And for example, mask. On the issue of mask, let's say we use the word wear mask, but do you repeat that? Do member of family, father uses it, comes back, then the son uses it? We need to clarify these sort of detailed usage issues actually. Without that, you have these communication gaps. So I think community engage is must, but we have to customize the community messaging. We actually did, for example, at the one hand, we spread the idea of panic syndrome. In a way, it happened. On the other hand, we really went out on that issue of hand washing and forgetting handshake and all that, distancing. Now, distancing part really hasn't worked too well because of the crowded thing. Hand washing and the cuff etiquette, I think this is there has been some impact, I think, on this issue. And down the line, I personally feel maybe, hopefully, and we pray that this pandemic comes to an end sooner than later. But I think this should also, we should take some longer term lessons here. For example, I see for Bangladesh, we should really embrace public hygiene as a long-term, permanent cultural shift on the whole issue of public hygiene, cuff etiquette and all that. And those are the way we need to think about it. Okay.
Thank you, sir. David, there is one more question to you about the vaccines that you are talking about. How feasible and how quick can we get a vaccine even at our level? Somebody is talking that we will produce vaccine in USA or UK. Why would we share first to Bangladesh or to other country? What do you think, this priority, how is it going to be prioritized using the vaccines, even if it is available as an effective vaccine? Please.
Thank you, Nitish. But before I start, I'd just like to second what Professor Hussain has said, because it's absolutely right that communities must play a very important role, and people individually must understand how to protect themselves and how to protect others if they're sick. So I thought that was a very important intervention on your part, Professor Hussain. Regarding vaccines, there are vaccines that are in human trial. There are a couple of them that are being tried in humans. There's talk even of using young adults as possible guinea pigs and actually exposing them to the virus to see whether or not they're protected by some of these experimental vaccines. But no matter what happens, I mean, there are over 95 different vaccines being studied. No matter what happens in these vaccines, they must go through a certain rigorous testing. They must be shown to be effective. They must be shown to produce immunity that lasts a certain length of time. And they must understand whether or not booster doses are required, whether 2 doses are required at the start. And also they must be licensed by regulatory agencies. The usual time for a vaccine is years rather than months for a vaccine that's being developed. And remember, there still is not a vaccine for HIV, for malaria, or many other diseases. There's a malaria vaccine, but not as effective as we would like. And so vaccine research is a long process. Hopefully, though, these new types of virus vaccine may be developed more rapidly, will be effective. And if so, there could be licensing sometime next year, it's believed. If that's the case, then the challenge will be making sure that there's an equitable distribution to those people who need it. And as you mentioned, Nitish, countries will be trying to be first in line, trying to buy up all the vaccines. And so that's a role for WHO and others to make sure that if there is a vaccine, there's a way that it can be distributed very equally within populations throughout the world, a real challenge. That challenge has been met to a certain extent with influenza. As you know, there's a pandemic influenza preparedness framework, which does provide for vaccine to developing countries. But, you know, that framework is only for pandemic influenza vaccine. So we have a long way to go. And so the short answer is we hope there will be a vaccine. It's feasible that there could be an effective vaccine developed, possibly by the end of this year or next year, that's shown it's effective. And then it needs to be licensed and produced. So a vaccine is a long way off. And what we need to do is exactly what Professor Hussain said, is make sure that in communities we're paying attention to what's going on and helping people to understand how to protect themselves and protect others. Thank you.
Thank you. One question to Dr. Hussain Rahman about, the balance in budgeting, in the present condition. How do you think the traditional way of budgeting is okay, or we have to look for a different approach to make a balance of a budget that will have a influence or focus on the public health? What is your opinion about focusing on these public health issues in the budgeting manner?
I think that's an absolutely pertinent question. And the question, of course, is the message is very clear, but I'm not very sure whether the policy audience is hearing the message as clearly. I think the pandemic has shown that it's not just a question of tinkering with the budget at the margin. Okay, let's give another 1 crore taka to the health sector. We cannot think about in a post or in a COVID-19 reality, we cannot think about the budget in this minor tinkering sense. This calls for a fundamental rethinking of our whole development approach as a whole, actually. We have, really not focused on public health in a big manner. But here, I think in the Bangladesh context, we also have seen this very important issue of budget, certainly, but how budgets are effectively utilized is also an issue. And I think particularly in the Bangladesh context, in the last 2 months, what has really driven home is a fundamental institutional reform of the health authorities. That has become a fundamental requirement, actually. We have seen some of this communication failure, the system preparedness failure, and some of the, really on inability to ramp up testing, etc. These are, I think, with budget, we have to say 2 things. One is that much greater attention to health and public health. I think in the people's mind, and I would urge One Health community to also bridge this gap, that what are the images which enters my head when I use the word health? Is it healthcare or health in a larger sense? Because we have been trained to understand health in terms of going to a doctor, but not in terms of the preventive part of it, not in terms of the public health aspect of it. I think there is a great opportunity here to really drive a more holistic health discourse. And the budget also, certainly, I am not particularly hopeful that the coming budget in next month in Bangladesh will have factored in sufficiently the challenge of COVID-19. But we also need to push, for example, budgets do not look at the enhancing the financial capacity of municipalities to deal with public health via waste management and all that. Budgets need to also go there also, actually. So as a whole, I would say that a fundamental rethinking of not just budget as a whole only, but also development approach as a whole needs to be thought through. And when we mention health, it must at the same time think of the health of the people, health of our environment, and health of our locations. All have to be considered simultaneously, and budget provisions made available accordingly. Thank you.
Thank you. I have a very common question to both of you. Maybe that is the last bit, and Dr. Hussain Rahman. We are One Health community. We strongly believe national, regional, and international coordination collaboration. And do you think under this sort of crisis, a crisis and unprecedented in nature, are we really collaborating globally, regionally, and nationally in a proper way? And is that a hope that in future our global community will get strongly united to fight this out, COVID-19? What is your impression about the current nature of collaboration, and how do you see the future of that? Over to David first.
Thank you, Nitish. I think what's very important to understand today is that despite the geopolitical tensions that are occurring, especially between the US and China, the technical people from those countries and other countries around the world are freely sharing information about this outbreak. And that information has permitted us to have the understanding that we have about this virus in a very short period of time. I actually chair a group at WHO that is the advisory group to the emergencies program. And we regularly have presentations from China, from Iran, from Mongolia, all countries of the world are providing information to WHO so that we can review this information, better understand the virus and its epidemiology, and also understand how we might work together to stop this outbreak. But then at the political level above that, there are discussions and there are distractions, and there are ways in which we're not working together. And so hopefully this collaboration in the technical community can move up to a political collaboration as well, so that we can make sure that there's equal distribution of vaccines, equal distribution of drugs, and equal distribution of knowledge will continue through the technical collaboration that's going on at present. So I'm very optimistic that we can continue together along the road. We have to give WHO credit for having brought us this far along with others, but it will be a big challenge if there is a vaccine to make sure that that vaccine is equally distributed throughout the world. And I know WHO and others will continue to fight to make sure that that happens. But voices from Bangladesh and other countries are also very important in that discussion and argument. Thank you.
Dr. Hussainul Rahman, please.
Yes. I would echo what David Heymann said, that yes, I mean, I don't think we should be unduly optimistic. I mean, we need to temper our, we need to, in a way, look at the evolving realities on the ground. And I think what that is telling us is that, yes, at the technical level, there is collaboration. And I think at the popular level also, I would add that to what David Heymann said, that at the popular level too, I think the fact that, this has come out of nowhere and has really posed a question to all our thinking about what is development and what it means to be a developed country. That I think has sunk, at some level it is sinking into people's mind. Not evenly, that is, I must say so. So there are these three levels, I think. I would add this other level. At the level of the people, what it means to be developed. And in that context, this whole issue of health, bringing it in a larger way, that's one area needs to work on. At the level of the technical people, the collaboration that's happening, I can see that that's a very cause for, that's the cause for optimism in some sense. At the political level, I think there is also the distraction that is true, and we can see those distractions loud and clear as soon as you open the TVs. But also I think at the political level, there is a learning curve also happening in terms of how to balance the needs of health and economy. I think the answers are also not really already known in a way. We are having to find the answers as we go along. How to ease the lockdown, what areas of innovations to really pursue, strengthen, etc. So that's happening. On the people's level, I think, as I said, hygiene, if it becomes, I would be the happiest if in a year's time, hygiene had become internalized as a cultural new approach actually as a whole. I think that would be a fantastic achievement for humanity at large. But I think I would end on that point that it's, I know the technical people, at that level that David Heymann mentioned, people at a very high level of expertise, they're talking, of course, with knowledge, etc. But I think there are this ground level knowledge being created in terms of how people are responding. For example, social distancing and the hand washing problems in urban informal settlements. How are people really customizing, trying to solve that issue? I think documenting this knowledge as it is happening on the ground is a very important research job. We need to do that. I was talking to colleagues from Kenya and Sierra Leone yesterday, and how that idea of quarantine, how that is evolved. In Kenya, initially it was seen as a punitive thing, only institutional quarantine. They didn't even understand the issue of home quarantine. Now they have moved towards that. The changes that's happening. And on the ground, for example, I would be advocating very strongly in the coming budget that there should be sufficient allocation for public hand washing stations in urban informal settlements. We may not be able to solve pipe water to every slum house, but there should be community hand washing stations easily available, and there should be concrete budgetary allocations for those. So these sort of knowledge on the ground of how people are coping, I think that's a useful complement to the technical knowledge that's being created at another tier. And I think we need to tap, and I would urge WHO to really be open and encourage the documentation and the collection of this knowledge. Our organization, the Power and Participation Research Center, we are doing this research. We are going to do another round next month, looking at these, trying to document this knowledge. And BRAC, that NGO that I chair, they are also actually very much active. I've encouraged them also to try and also do a knowledge learning curve as they are acting on the ground, because what I would like to close on is that none of us have all the answers in our hand. No one has all the answers. Technical people are coming up with certain answers. The policymakers are coming up with certain answers. At the level of community and the social workers, they are having to come up with the answers. So let's make sure that we are documenting the knowledge, editing it as it merits, and use that knowledge to funnel the type of solutions that we are trying to create for the type of future that we are all aspiring to. I'll end there. Thank you.
Thank you, David. Before we conclude, you have some small questions that you need to answer. Can you tell us whether there is any antigen-based test other than PCR?
There is an antigen ELISA test under development, but the only test that's really been validated is the PCR.
And when you talk about antibody test, does it mean to detect the disease or just to assess the immunity level?
Well, the IgG antibody tests, which is what most of them are, are looking for previous history of disease. But there are some IgM antibody tests that might be useful in the future in diagnosis, but it would be a late diagnosis. It wouldn't be as early as is PCR. Over.
Yeah, David, that is the last question that I would like to ask you. You talk about the asymptomatic infection, and do you think there are carrier as well? After recovering, when we declare somebody recovered, can he or can she be a carrier for the virus or not?
Well, the question is, how long do people continue to shed virus after they've recovered? And what most people are saying is that they should, from the day of onset of illness, it could be up to 14 days. But some countries are treating it as less, some as more. There's really no precise information understood yet. But most people are using 14 days from the onset of illness as the time when people should be released and be safe from transmitting to others.
Okay, and the last question. We have been working for One Health, for last 2 decades or less than 2 decades. What is the future of the One Health movement globally? This is for both of you. I mean, the attitudes, the practice, as well as the current political, crisis or these difference of opinion. What do you think about the future of the One Health movement globally as well as regionally and nationally? David, can you start, please?
Yeah, I would just start by saying that Bangladesh has an excellent platform for One Health. And it's been a pleasure to be out in Bangladesh and work with you many times, talking with both people from animal and human health. And that really is the future, because we need not to just react to these infections in the future. We need to be able to predict them, and we need to be able to make sure that humans don't become infected because we missed the infection in animals. We must be working together to make sure that we're all doing our job in preventing as many of these emerging infections as we can. And as I say, it's been a pleasure to work in Bangladesh in the past and see how rapidly you've advanced the concept of One Health within Bangladesh, which needs to also be advancing rapidly globally. And thankfully, there are countries like Bangladesh that are pushing it forward. But I would just say that it's been a great pleasure to talk with you today. And I've really learned a lot from Professor Hossain on what's going on in Bangladesh during this outbreak. And I've appreciated participating. I will have to leave right at past because I have another conference. But I will, I'd like to thank you and thank Professor Hossain for all the information that I've learned from him.
Thank you, David.
To you.
Thank you, David, so much.
Thank you very much.
Thank you so much for your time. And it was so enlightening. Thank you very much. Dr. Hussain Rahman, please.
Yes, well, I also thank you, Nitish, for organizing this. Thank Professor David Heymann for his inputs too. And I'll say about the One Health, I think I see there are two windows in which one needs to work. One, of course, is the technical one. In fact, that if you're talking of One Health, meaning linkages between multiple paradigms, multiple agendas, that needs to be fleshed out more. I mean, there are work to be done, as I said, to be done. And the other one is to have the actual conversations between various communities. And I think there, this multi-stakeholder conversations are so critical. And we need additional platforms there. I would like to say that we have this also a platform called Healthy Bangladesh. I think Nitish may be aware of that, where we try to encourage these multi-stakeholder consultations, particularly at the level of the communities. We have been focusing on our cities, and this Healthy Bangladesh platform, we have really created it to encourage these multi-stakeholder consultations. People who didn't feel that they need to talk to each other. By talking to each other, they find that, no, it is useful. At the end of the day, people should feel that there is a value addition because of this conversing with other communities. So I would, hopefully, One Health is a very important concept, and I think we need to push that both from that point of view of substance, but also in terms of these social conversations that are needed to be continued. So I also would like to thank everyone, and particularly Nitish and the organizers for inviting me to participate in this very informative webinar.
Okay, I think we are now at the end of the whole session. Sir, thank you very much for your kind participation, and also it is so deeply enthusiastic conversation. I must congratulate you for your kind participation and discussion. Ladies and gentlemen, I will have to conclude it here. Normally it has more than half an hour now above our time, but it was a very useful one. As I said before you go, there is one small announcement. We will have another webinar in next Thursday at the same time. We will circulate our announcement tomorrow or today, and also it will be uploaded. The whole discussion has been recorded. It will be uploaded in our One Health website. And thank you very much again for your enthusiastic participation. The question that you have already sent, we may not have answered all, but they are all in our storage. We are keeping them, and you will be getting those answers later on. And with these few words, again, many, many thanks for your participation in this particular webinar. Thank you indeed.
Nitish, if you kindly share the access to the One Health website, that will be appreciated.
We will do that, sir. Thank you very much.
Thank you.
And thank you from our side, from our One Health Bangladesh, as well as Global Health Development. And I am Nitish Devnath, National One Health Coordinator. Thank you very much. Here is the end of our today's webinar. Thank you.